Now we're going to be going through a needle decompression. Now needle decompression is indicated when signs of a tension pneumothorax are apparent. For example, signs of hypoxia, hypotension, tachycardia, decreased air entry on the affected side or no air entry at all, subcutaneous emphysema on palpation, deviated trachea, and increased difficulty in ventilation, cyanosis, anxiety, those signs. Now we'll go through some of the equipment that we're going to need. So here we have a 9 centimetre dwell cath. They're usually anywhere between 8 and 9 centimetres long, and it comes with a small scalpel type blade with the kit. We have a Heimlich valve for connection after decompression, a vinyl connecting tube, a 10 ml syringe with 4 ml of normal saline to test the location of the needle. We got local anaesthetic, lignocaine 1% here, and we've got our kits over here, analgesia, other medications as required. Got the oxygen, patient is on supplemental oxygen, and observation equipment. Now we're going to go through the steps to perform a needle decompression. First of all, we're going to identify the second intercostal space, mid-clavicular line. We're going to mark this site with a pen, and we'll get an offsider to check that this is indeed the correct location. Next step is we're going to cleanse the skin. We can use an alcohol swab for this. So we'll cleanse where we're going to perform the decompression. Now, we're going to keep the patient on the supplemental oxygen, keep the patient on the monitor, SATS probe, cardiac monitoring. Now, while we're doing this, we're going to not use any positive pressure ventilation or PEEP. If the patient is conscious, make sure we've administered the appropriate analgesia, and we'll even use local anaesthetic in the area. Here we have 2 ml of lignocaine 1%. We'll administer that in the area subcutaneously and a bit into the tissue. All right, we'll give that a minute to take effect, and we'll make sure we've got all our equipment ready. Now, what we're going to do next is we're going to attach our syringe with 4 ml of normal saline to the dwell cath. All right, then we're going to take the little scalpel here, which makes an incision over the site. Make the incision there, we'll dispose of this appropriately. We'll take our dwell cath out, and we'll make sure that we insert this at 90 degrees to the chest wall, making sure we're going straight down. We'll progress the needle down. Right. And now we might hear a rush of air, or with the syringe attached, we might see some bubbles form. When you think you're in the pleural cavity, draw back on the needle, and you might see some bubbles there. When you see bubbles there, you're in the right spot. Then you can take the needle out and progress the Teflon into the pleural cavity, and make sure you have correct sharps management. All right, now we should be looking for a improvement in the patient's condition. We'll auscultate the chest, seeing if there's any improvement in air entry. Now, we don't have a 3-way tap. You could consider applying a 3-way tap here for ongoing aspirations. We will secure, with tape, we'll secure the Teflon there. We can connect our vinyl connector to the end, and the Heimlich valve we can connect there. If you have a catheter bag or something, you can also plug that onto the end to drain any fluids out, and we can take that to the patient's chest. This works as a 1-way valve, so air can escape and not re-enter. Now, if the patient begins to develop a tension pneumothorax on the same side again, we could consider a second needle decompression, leaving this one in place and locked off with the 3-way tap. We'll just make sure we insert this 1 centimetre next to the existing one. Now, this is not definitive. This patient will need a chest drain for definitive care as soon as possible. Now, the second intercostal space, mid-clavicular line, might not be the only place to perform a needle thoracotomy, as an 8 to 9 centimetre dwell cath needle can cause more damage to underlying structures but unfortunately it's required to reach the pleural cavity in a larger cohort of patients. Using a 5 centimetre needle has been shown to be ineffective when used in the second intercostal space mid-clavicular line, but is shown to have good benefits when used in the 4th or 5th intercostal space anterior axillary line due to significantly thinner chest wall thickness and nearly 0% rate of patient injury when used there. So it's just food for thought when considering the size of needles you're going to use. Lastly, just some complications to be aware of when performing a needle decompression. First of all is the misplacement. If you don't go 90 degrees to the skin and you go in on too shallow of an angle, you could push the needle into the subcutaneous tissue and it'll be ineffective. You've got to make sure pushing the needle into the second intercostal space in the mid-clavicular line, you want to put the needle as close to the bottom rib as you can. This is just to make sure you don't hit the neurovascular bundle and cause a big hemorrhage. If the decompression is on the left-hand side, make sure you don't go on too much of an angle because you don't want to be hitting that aortic arch. Lastly, the last complication is failure to recognise inadequate evacuation of the air from the pleural cavity. So be sure to constantly reassess the patient's respiratory status and observations. Thanks for watching. That is needle decompression.